Hello again. I'm back. We're going to go from talking about strokes to the thing that causes stroke. So we're going to talk about AFib right now, irregular. The cutting edge management of atrial fibrillation. I have actually no disclosures, but I do have sort of one disclosure, is that I love AFib. I really love it. I think it is a great thing to talk about. It's a very common disease, right? I'm not even going to ask because I know that you've all taken care of patients with atrial fibrillation. I'm going to guess that if you practice regularly, you're taking care of someone who either presents for an AFib-related complaint or has a history of AFib probably every week, if not every other week of your practice. I feel like it's almost every other day, because by the time you're 80 years old, there's a 10% chance that someone 80 or older has atrial fibrillation, not necessarily as their chief complaint for coming to the emergency department, but they have it or they've had it in the past. So it is an incredibly common disease, and there's a lot of evidence behind it to guide our practice. So I really like talking about it because it's something where we can really make an impact and make an impact based on evidence that's out there. So we're going to talk about ways to treat it, what are kind of your general strategies, what are the specifics about how to treat it, and then of course that feared complication of stroke, your thromboembolic risk prevention, and then what causes the AFib to happen in the first place. First off, we're starting with an EKG. What do you see on this EKG? I know you're all thinking AFib because that's what we're talking about, right? But more specifically, how do you know this is AFib? Right, it's fast, it's narrow, and it's irregular, right? And you don't see any P waves. Now, are P waves there? There are P waves there. There are going to be P waves buried, and you may see a P wave that pops out every now and again, but you're not going to regularly see P waves in there. So if you see one P wave in a rhythm strip, two P waves on an EKG, don't let that throw you off. Again, you want to differentiate this from MAT, as we talked about an hour or so ago, but this is atrial fibrillation. There are no P waves that you're going to see consistently, okay? And it's fast, right? It's rapid ventricular response, meaning that the rate is greater than 110 beats per minute. So there you go. You can see that it's definitely irregular. Blow that up for you so you can see that the R distance between the QRS complexes varies between each beat. So what's the first thing you want to know? You get this EKG put down. What do you want to know about this patient? Right, what do they look like? Is it this guy, sort of what we talked about last time, who's sort of sitting up looking okay? Or is it this other guy who's laying back, his eyes are closed, there's sweat beating down his face? That guy is not looking good, right? And which one obviously is going to get your attention first? I'm going to go with the sweaty guy laying back with his eyes closed. That's where I'm going to triage my time and go see him first. That's an unstable patient. So how do we define unstable? Some of it's relatively straightforward, right? If the patient is hypotensive. I don't think anyone's going to see someone with that heart rate and a low blood pressure, 80/40 or something like that, and have to think about whether or not that patient is unstable. They are clearly unstable. But also things like congestive heart failure. Is your patient sort of frothing, or they have that kind of wet, pinkish kind of cough coming up? Do they feel short of breath? Do they have JVD up to their earlobes? Are they confused? Is this new mental status change maybe related to hypoxia, or maybe related to hypotension? Or do they have signs or symptoms of cardiac ischemia or cardiac infarction, right? Everything that you would think about for someone coming in, could they be having an MI? If those symptoms are present in the setting of AFib with RVR, that patient's not tolerating that heart rate. They're essentially failing their self-imposed stress test. So what do? You keep calm and you shock on, all right? If there's one thing you want to know from this patient is how long has this symptom been going on, right? Because you have that magical 48-hour cutoff that we were all taught. We'll talk about the data behind that a little bit more. After 48 hours of atrial fibrillation, your risk of having a thromboembolic event, aka stroke, goes up. Within the first 48 hours, your risk is significantly lower. But asking that is a little bit not as important right here, because either way, both arrows lead to the same common treatment, and that treatment is electricity, right? You have an unstable patient. Yes, if the symptoms have been going on for greater than 48 hours, the risk of that patient having a thromboembolic event when you cardiovert is higher. It's still low, but it's still higher than if it was fewer than 48 hours of symptoms, but you don't have much of a choice here, right? If you can get some anticoagulation on board before you hit that button to defibrillate, great, do that. But either way, don't delay your cardioversion because of the duration of symptoms if you have an unstable patient. What you need to do is get that heart rate slowed down, get them back into sinus rhythm as best as you can. Okay, there's your defibrillator, and again, there is a pulse. So you sync to that pulse, right? I know ACLS, if you remember back when you last took ACLS, creates all these algorithms when you sync, when you don't sync, these rhythms, those rhythms. If you have a pulse, you sync to it. There's no pulse, there's something to sync to. It's actually remarkably straightforward. There's a pulse, this person has a pulse, it's AFib, sync, and defibrillate. Okay. Now, how are we going to maximize the chance of success with a defibrillation? Well, it's a very easy intervention. Routinely, we put the pads in the parasternal area and the left lateral position. And that's pretty good. That works. But if you're going to increase your chance of first shock success, just take that lateral pad and rotate it around the back. Put that pad over the tip of the scapula on that left side. Pretty simple thing to do. Now, if your patient is really unstable and maybe really big and sweaty and you can't get that pad around the side, so be it, understandable. But if you can, try and put that pad back there. Pretty simple intervention with first-time shock in the anterior lateral positioning. You have a 76% conversion rate for AFib, and just by moving that around, you go from 76 to 87% with that very, very simple intervention. Okay. If you're still going with paddles, that's fine. Go with paddles. The way to increase your first shock success with paddles is to really lean in on those paddles. It's especially important with America getting heavier. If you have a patient who's obese or has a very large AP diameter for something like COPD, you literally lean in on those paddles to compress the chest, force the patient to exhale, decrease the resistance of that chest, let that electricity get to the heart as best as you can. Again, relatively simple, low-tech interventions. You already have all this equipment. Position your pads a little bit differently. Lean in on those paddles if that's what you're using, and go ahead and do a synchronized shock. Now we're going to circle back to the stable patient here for a moment. A little less exciting, less of an adrenaline rush. I know, we all come to work for that unstable patient. We want to go in and fix them. But this is the majority of what we're going to see, right? The stable atrial fibrillation patient. And here is where it becomes more important to know the duration of symptoms. How long have you had your symptoms? Has it been fewer than 48 hours or more than 48 hours, or are you not sure? If you're not sure, they've been stuttering, a little on, a little off, not quite sure, had some a few days ago, now they're back. You can really think of this as, do you know that you've had your symptoms for fewer than 48 hours, or are you not sure? So it's fewer than 48 hours or not sure are truly your two categories of how to break someone down. And the difference is tremendous because it changes your management options. If you have symptoms of fewer than 48 hours, you got two choices. You can go with rhythm control or you can go with rate control. Either one is perfectly fine. If you've had symptoms for more than 48 hours, or more specifically, if the patient is not certain that they've had their symptoms for fewer than 48 hours, you have to go with rate control. And that is, again, because we know beyond 48 hours of irregular atrial contraction, you're at risk for developing a thrombus and then having a stroke. Then you get to do the HINTS exam that you just learned about. But that's not what we're talking about this hour. All right, so poll of the crowd. When someone comes in with AFib with RVR, who generally starts with a rhythm control strategy? Rhythm control strategy. So maybe, that's pretty good. I'd say maybe 25%. And rate control? Okay, and everyone else runs away or picks up the next chart? Is that, okay, just checking. Okay, so actually a fair amount goes straight to a rhythm control strategy, and that really makes me happy. You don't know how happy that makes me. That actually really makes me happy. So we're going to talk about some of the evidence and also some of the lack of evidence behind going with directly with a rhythm control strategy. So rate versus rhythm, that's the age-old question, right? There are the two studies, the two big studies were the AFFIRM study and the RACE study. Between the two of them, there were over 4,000 patients, like 4,500 patients there, and they looked at what was better. Was rate control better or was rhythm control better? And they looked at things like heart attacks and congestive heart failure and strokes and even things like quality of life. And the answer was it was a wash. One did not have any superiority over the other. However, there is a major, major limitation to these studies that was not really realized at the time. And that is when someone was rhythm controlled, they were considered to be done. You're rhythm controlled, you're fixed, that's it. We're not going to worry about your thromboembolic risk anymore because you're no longer in atrial fibrillation. Well, the studies had about, at 1 year follow-up, 23% of the patients were still in sinus rhythm. Do you know what the other 77% of those patients were doing? They were back in atrial fibrillation, and they were walking around in atrial fibrillation of unknown duration, sometime from the time they left the hospital to the time of follow-up, and not anticoagulated, even if they were high risk for having a stroke. So that is really a major limitation to those studies. So do I have a definitive answer? I don't have a definitive answer yet, and I'll share my opinion as we talk more about the evidence. So as of right now, the balance seems to be equal, rate control versus rhythm control. And this is the statement from 2016 from the European Society of Cardiology. Although many clinicians believe that maintaining sinus rhythm can improve outcomes in atrial fibrillation patients, all trials that have compared rhythm and rate control to rate control alone with appropriate anticoagulation have resulted in neutral outcomes. That's a lot of words. Let me break that down for you just a little bit. They took patients who were rhythm controlled and also perhaps rate controlled within the rhythm control to patients who were just rate controlled and rhythm wasn't even addressed. The patients who were rate controlled were risk stratified for thromboembolic risk. They had appropriate anticoagulation, and they looked at those same outcomes: quality of life, heart attack, strokes, all of that. But the majority of the studies that they're referring to come up with this consensus statement, the vast majority, did not address the thromboembolic risk of the patients who were rhythm controlled. So again, sort of same data, we're looking at a different way, limitations. As of right now, it seems to be an equal balance. I strongly, strongly suspect that as time passes, I don't think there's going to be a lot of time, we're going to shift a lot more towards rhythm control and away from rate control, which is why I think it's so important to talk about this now. Even now, however, there is one major caveat. For patients that are younger than 65 years old, so your young AFib patient, by AFib standards, 60 is young. So young AFib patients, those patients do seem to benefit from rhythm control. They have lower all-cause mortality when they're rhythm controlled versus rate controlled. And that's thought to be related to the cardiac remodeling that happens when your heart's in atrial fibrillation, and obviously the younger you go into AFib, the more time you have to remodel, the higher the possibility of having adverse outcomes. So for patients under 65, rhythm control is the way you want to go if you can. Patients over 65, as of right now, I cannot tell you the evidence tells you to do one versus the other. So either one, whatever you feel comfortable with, whatever is best for that patient in that situation. But I do suspect as we keep looking at this data and more smaller studies come out, we're going to find out that rhythm control probably does have some benefit. That right now is my opinion based on reading the evidence. It's not consensus statement by anyone as of yet. Okay, so we go with rate control. We got our standard agents, right? Same ones we talked about for the other narrow complex tachycardias. Beta blockers, calcium channel blockers, but here we're also going to talk about amiodarone, which has characteristics of both. Beta blockers, standard stuff, metoprolol, esmolol strictly IV. You have a short half-life with esmolol, so if you have someone who you're a little worried about that blood pressure, just a little bit lower than you might like to push metoprolol, you can think about giving esmolol. It's a relatively short half-life. As well as your calcium channel blockers, two main players, diltiazem and verapamil, both work equally as well. Neither one causes more hypotension than the other. Verapamil does not cause more hypertension than diltiazem. I kind of think that's a bit of urban legend. They both have a risk for hypotension, same as beta blockers do. And then, of course, amiodarone. All right. So which one should you use? Here's a breakdown. And if you look at it, it's a little complicated, but it really simplifies pretty nicely. If you have no other disease, if you have hypertension, if you have preserved ejection fraction, and you can if you can keep all this in your head, that's fantastic. But to keep it simple, if you look, every option there is a beta blocker or a calcium channel blocker, except for the patient with known left ventricular dysfunction or a patient that presents an acute congestive heart failure. That is a situation alone where you're going to want to avoid your calcium channel blockers. Go with the beta blocker. Everything else, dealer's choice. We're in Vegas. I had to get a dealer's choice phrase in there, right? Dealer's choice. Calcium channel blocker or beta blocker. Now, if I don't know someone's ejection fraction, and they come in, they're not in congestive heart failure, I don't know their ejection fraction, I don't really worry about this particularly. I go ahead and either give a calcium channel blocker or a beta blocker. I don't remove calcium channel blockers from my toolbox if they do not have a known low ejection fraction. And why is that? Well, here's the 2014 consensus statement by the American Heart Association, American College of Cardiology. You can read all of that. And one of their lines is non-dihydrohydropyridine calcium channel blockers should not be used in decompensated congestive heart failure. Reasonable statement. It's category 3 harm, level of evidence C, and that last box that says NA is usually where the reference is so that you can read the primary study that provided the data for the consensus statement. There's no reference. This consensus statement by these three major organizations puts the statement out, which is a reasonable statement, but there's no actual evidence behind it. So it's something we all sort of accept. Don't give calcium channel blockers to patients in acute decompensated congestive heart failure or patients with known low ejection fraction, but we're really doing it based on expert opinion and not on evidence. So I don't sweat it too much. If I don't know that that patient has a low ejection fraction, I go ahead and give a calcium channel blocker if that's what I feel is appropriate. So I don't take that out of my choice. Either way, absent that, beta blocker, calcium channel blocker for rate control, your choice. Calcium channel blockers, do they work? Yeah, they work. Standard dose of diltiazem, 0.25 milligrams per kilogram, right? That's the standard. What if that blood pressure is just a little bit lower than you might like for that patient? It's not exactly hypotensive, but they have a history of hypertension. Now their blood pressure's like, their systolic's like 105, and you're feeling maybe a little tenuous about giving that dose of diltiazem. Well, the good news is that lower doses work and have lower associated incidence of hypotension. Doses as low as 0.125 milligrams per kilogram do work for rate control in atrial fibrillation and have a lower risk of hypotension. So if you're a little on that fence, I know I don't want to shock this guy, they're not really exactly unstable, I want to try and rate control them, you can go with low dose calcium channel blockers. And that is something that I actually do routinely. Right? And that's one of the cases where I would definitely go with a calcium channel blocker over a beta blocker because I know I can really give relatively low doses of diltiazem, still have an effect, decrease risk of hypotension. Does anyone pre-treat with calcium to try and prevent hypotension? No? Good. No hands going up. And that's good because it has been proven to not really do much of anything. You're not going to harm the patient. You know, I'm sure in Dr. Matu's lecture he always says, give them calcium. They might have stronger bones. That's fine. You're not going to hurt your patient by giving calcium, but you're not going to mitigate any hypotension related to your calcium channel blocker. Again, just another step, another drug, more staff time to get the medication, more cost. No harm, but really no help either. So why do we choose calcium channel blockers or beta blockers? There's no good evidence as to why we choose which one and which one is better for the patient. One study here just shows that what the doctor chose, the treating physician chose, was really based on what the patient's been on in the past. So if your patient's been treated with a beta blocker for whatever reason in the past, more likely to give a patient a beta blocker in the emergency department. Same thing with calcium channel blockers. It really doesn't matter. They both work. As long as you know the one relative contraindication to calcium channel blockers, get one that you feel comfortable with, go ahead and give that medication, get familiar with the dosing, get familiar with the possible side effects of it. Question also always comes up, what about COPD and beta blockers? No reason to not give beta blockers for a patient with a history of COPD. I think we talked a little bit earlier, if the patient is there and they are in having a COPD exacerbation, like they're actively bronchospastic, I would go with a calcium channel blocker, not with a beta blocker. But just for a history of COPD, even the patient has a history of bad COPD, they're not bronchospastic, then beta blockers, there's no evidence that you're actually going to throw a patient into a COPD bronchospastic exacerbation by giving them beta blockers. So your life gets kind of easy, right? You choose. You pick the agent you're most comfortable with, and you go ahead and give that agent. All right. Now, I was very happy to see that so many people were talking about going directly to rhythm control, and I think that that's wonderful. Remember, especially with that young patient under 65 years old with AFib, they're really going to benefit from that. We have two main options here, right? Electricity and drugs, pharmacologic. So of the folks who said they go straight to rhythm control, I'm curious, who uses pharmacologic agents as first line? So much smaller subset there. And electricity? Yeah, okay, all right. So vast majority electricity, a few pharmacologic. Both are valid. Some are more effective, some are safer. So we'll talk about that in more detail too. So the time of onset. So everyone, we worry, and appropriately worry, about causing a stroke, right? When we defibrillate that patient, either electrically or pharmacologically, and by the way, there is no difference in stroke risk if you use chemicals to cardiovert the patient or if you use electricity. So don't feel if you feel unsafe doing it with electricity, feel equally unsafe doing it with medicine. The risk is the same, but hopefully you feel safe with both. The risk changes at 48 hours. The risk remains low, but it goes up. And the question always comes up, how do I know? How do I know that my patient really knows when they came into their atrial fibrillation? What about this idea of silent atrial fibrillation, right? And silent atrial fibrillation absolutely exists. We know that it exists. There was a meta-analysis of 3 studies, looked at over 10,000 patients that were monitored for 2 years. These people wore heart monitors for 2 years or had implantable monitors for 2 years. And about 10% of those patients had asymptomatic episodes of atrial fibrillation lasting for about 12 hours. The overall risk of CVA incidence, not risk, the incidence of CVA in that group was 0.23%. Really, really low. So we know silent AFib exists. For some reason, silent AFib does not appear to be the same CVA, carry the same CVA thromboembolic risk as AFib with symptoms. So either way, silent AFib exists, but every single study talking about the risk of having a thromboembolic event related to your AFib is all determined by the time of onset of the symptoms. And that sort of makes sense because most people aren't wearing a cardiac monitor before they come in to see you. You put them on the monitor, you go based on their symptoms. So yes, silent AFib does exist. Every study that I have read about calculating the risk and the time to risk of increase for having a CVA is all based on patient symptoms. So take the concern about the silent AFib and put it off to the side. Listen to your patient, listen to what they tell you when they first had their symptoms. This is not someone who went for their annual checkup at their primary care doctor's office, was found to be an AFib and came into your emergency department. Different patient. Definitively not known to be fewer than 48 hours. But if a patient comes in and said, I had my palpitations at this time when I was doing this activity, I felt my symptoms come on, that's usually pretty reliable. All right, so cardiovert. There's a low but known risk of a stroke, right? We all don't want to do any harm to our patients. We only want to help our patients. So let's look at the data and see really what is that risk if we're going to cardiovert someone. A lot of information here. I just only want you to look at one line. And this line talks about the thromboembolic risk. This is a study done in JAMA, and it looked at patients all within 48 hours of symptoms, but they broke it down even further. They said who had symptoms for fewer than 12 hours, 12 to 24 hours, and 24 to 48 hours. Overall risk of a thromboembolic event, 0.7%. 0.7% cardioversion in the first 48 hours of symptoms. So really low. Risk of a thromboembolic event within the first 12 hours of symptoms, 0.3%. So really, really low in the first 12 hours of symptoms. So if you get someone in the first 48 hours of symptoms, still low risk, less than 1%. If you get someone in the first 12 hours of their symptoms, the risk is 0.3% of precipitating a thromboembolic event by cardioverting them. Right? That is extraordinarily low. So there are the numbers, low. And we know patients, especially young patients, who have benefit for getting out of atrial fibrillation and back into sinus rhythm sooner than a delayed watch and wait or rhythm control strategy. So go ahead and cardiovert. Electric. How do we do this? Same themes, right? Put the pads on the right spot, as we just talked about. Hit that sync button. They have a pulse, so sync to it. Deliver your defibrillation. 200 joules synchronized biphasic. Right? Pretty straightforward. 70 to 90% success rate. Now that's a pretty wide range, but you get higher towards that 90% when you do things like position your pads anterior, posterior as opposed to anterior, lateral. Deliver 200 joules, synchronize, one-time shock, biphasic. All of those things get you higher towards that 90%. So it works. It works well. And it's really hard to mess it up. You can have transient bradycardia, just so you know, so no one panics. If you shock the patient, they come back to sinus rhythm and their heart rate comes up slowly. Transient, doesn't require intervention, don't need to do much of anything. Definitely happens. The risk of adverse outcome is very, very low. So, shock. Pharmacologic. Pharmacologic works. Not as well, though, and the risks are higher. So I always think it's interesting when you give the choice to a patient and say, here's a pill and a glass of water, or here's this defibrillator. Which would you like me to do? I think the pill looks a lot more benign, but actually the pill is less effective and carries a significantly higher risk than the defibrillation. Okay? 4 main agents, there they are. You know, if you're going to give pharmacologic cardioverting agents in the emergency department, get 1 or 2 that you are familiar with and feel comfortable with as far as the side effects. All do carry a risk of side effects. Ibutylide, great medicine when it works, right? 4% risk of causing torsades. That's pretty significant. So you have to know about the side effects. A lot of them you can see they cause hypotension. They can cause other tachydysrhythmias like flutter with one-to-one conduction. Like anything else, if you know about them, you're prepared to deal with it. But these are the 4 you're generally going to be using in the emergency department if you're going to be using them at all. Flecainide, ibutylide, and propafenone. 50% success rate. 50% success with pharmacologic agents for cardioversion out of atrial fibrillation back into sinus rhythm. Does anyone have cardiologists at their institution they deal with that do the pill in the pocket? You're aware of that, the pill in the pocket technique? Yeah, I see a couple hands over here, pill in the pocket. So if you give the first dose of your pharmacologic agent and your patient doesn't have adverse effects, so it's generally done in a monitored setting like an emergency department or a CCU, somewhere along those lines, then we know the patient can get the benefit without getting the side effect. It's a pill in the pocket. If the patient feels their symptoms of atrial fibrillation come back on, they take their additional dose of ibutylide, flecainide, or propafenone before presenting back to the emergency department. So if someone comes in and says, I did the pill in the pocket technique, my doctor told me to take this when my symptoms came back, my symptoms are still going on, so I'm here to see you, that's what that means. Already did a trial of the medicine, didn't have side effects, take it as an outpatient, 50% of the time it should work, other 50% of the time they're coming to visit you. So now you're familiar with that technique. All right, how about magnesium? Does magnesium work for AFib? Right. There's a lot of literature out there about it, a lot of talk about it. Do we give magnesium? The answer to that is a little complicated. So as a sole agent, the answer is actually not complicated. As a sole agent, no. Doesn't work. Don't use magnesium as a rate control agent and don't use magnesium as a rhythm control agent in isolation. It simply doesn't work. There's lots of evidence telling us it doesn't work. However, it does have a synergistic effect with other AV nodal blocking agents. So if you give magnesium along with your diltiazem, or you give magnesium along with your metoprolol, you will have a positive effect. But as a sole agent, it does not work. Sometimes I'll see people, our residents will talk to me about using magnesium first and then kind of seeing what happens, then as a step in their algorithm, and that's not really a valid treatment algorithm. So give it, sure, give it in conjunction with something else, never as a sole agent. Anyone have any questions about the magnesium use? I think that's often a point of contention with off services about have you tried the magnesium? No? We're all good with magnesium? Yes? AV nodal blocking agents, so beta blockers or calcium channel blockers, either one. Yeah. Not for rhythm control. Correct, yes. Question is, would giving magnesium benefit your electrocardioversion success? You know, I don't know. There's evidence to tell me that one way or the other. I think you're not gonna harm your patient by taking 2 grams of magnesium. I kind of feel like it shouldn't help because you're using electricity to reset, but I don't think it's really gonna hurt anyone either. So the question was about rate control or rhythm control meds affecting cardioversion. And the answer to that is there actually is very good evidence that pre-treating with ibutylide increases your risk of successful electrical cardioversion. So if you are having someone who's refractory and you can't really get them out of AFib, I wouldn't start by giving ibutylide. I would start with standard synchronized cardioversion, proper pad placement by phasic defibrillator. But if that's not working, pre-treating with 1 milligram of ibutylide actually definitively does increase your risk of cardioversion success. So excellent question. Thank you for bringing that up. Okay. All right. Now that you've fixed the patient, you've either rhythm controlled them or rate controlled them. Rate control, by the way, is less than 110 beats per minute if your patient feels fine, less than 80 beats per minute if your patient remains symptomatic. Okay. So that used to be termed lenient rate control. Right? Strict rate control was everyone had to be less than 80. Looked at the data. If someone has a heart rate of 80 or someone has a heart rate of 110, no difference in outcomes. It sort of feels odd to leave someone with a history of coronary artery disease, congestive heart failure at a heart rate of 110 and call it a day. But the evidence says that you really don't need to drive their heart rate down any lower as long as they're feeling well with it. They're not symptomatic. So when that data came out, I thought my job just got 30 beats per minute easier, right? I can leave them at 110 beats per minute perfectly fine. That is adequate rate control. And then, along with all of this, and rate control and rhythm control, we have to worry about the thromboembolic risk, right? AFib, you carry 5 times the risk of having a stroke compared to the general population. That's pretty significant. How much do you think we spend in this country a year on atrial fibrillation, as a slight aside? This, United States, per year. Anyone have any guess out there? We spend about $8 billion in this country alone on the management of atrial fibrillation, and that does not include the cost of long-term care for AFib-related strokes. Indirect costs for atrial fibrillation are thought to be about $10 billion, so actually higher Indirect costs are actually higher than direct costs of atrial fibrillation. So between the direct and indirect, $18 billion in the United States alone on the management and care and indirect cost of atrial fibrillation. That's a lot. Every stroke that we can use the evidence and medication to prevent, we're obviously helping that one individual patient, and we're also helping the management of AFib in general and those direct and indirect costs of atrial fibrillation. So thromboembolic risk, definitely a real risk factor. Anyone taking care of a patient with a history of AFib who came in with a stroke? I'm sure, right? I see just a lot of nods. It's probably not even worth putting your hand up because you practice long enough, you're absolutely going to. People who don't take their meds or can't afford to get their meds or weren't prescribed their meds for some reason, had a gap in their meds, these patients are all at huge risk for having strokes. All right, so it doesn't matter. It doesn't matter if you are in AFib or I got you back into sinus rhythm in the emergency department. Either way, I have to assess your risk for a thromboembolic stroke. Because remember, 77% of patients were back in AFib at 1 year follow-up. You know the Ottawa aggressive protocol? Got a lot of press. Ottawa, Canada, they try and get everyone home. They treated patients. They got something 90+% of those patients out of the emergency department to get them back to sinus rhythm. They had 1 week follow-up. 1 week follow-up. 8% of the patients were already back in AFib within 1 week of their follow-up. So you have to manage this thromboembolic risk. You have to assess it and then manage it. Okay. All right. So how do we determine it? CHA2DS2-VASc score. This beautiful score that's put out there assesses your risk of having a stroke annually related to atrial fibrillation. Not a reason in the world to memorize this. Yes, there is an app for that. You know, it is kind of nice because C is for congestive and H is for hypertension and age. So it's kind of a mnemonic in there that you can remember, but there's really no need. You can look it up. This is not, you don't have to, there's no emergency to calculate the CHA2DS2-VASc score. It's not, you have to do it at the bedside. You can take your time and calculate it. So you calculate this score, and let's talk about what that means. Your higher your CHA2DS2-VASc score, the higher your annual incidence of having an AFib-related stroke. So if you look, if your CHA2DS2-VASc score is 0, you essentially have a 0% chance of having a stroke related to your atrial fibrillation over the next year. If your CHA2DS2-VASc score is 2, you cross that 2% threshold that we set for so many things in medicine, you have a 2.2% annual risk of having a stroke related to your AFib. And then as your number goes up, your risk goes up. Pretty straightforward. The quandary becomes, what if your CHA2DS2-VASc score is 1? 1.3% risk of having an AFib-related stroke over the next year. Well, anticoagulation isn't without risks. That's sort of where the risk-benefit comes a little trickier. What do you do with that? Let's take a look at what some of the guidelines tell us. Again, this is a consensus statement from 2014. CHA2DS2-VASc score is greater than or equal to 2, anticoagulate it. That's pretty straightforward. If your CHA2DS2-VASc score is 0, don't anticoagulate. That's pretty straightforward. And that's the nice thing about the CHA2DS2-VASc score. If your score is 0, we don't have to worry about anticoagulation for you. The evidence is there. The consensus statement is there. The patient does not need to be anticoagulated. If your CHA2DS2-VASc score is 1, well, this is where they gave the big hedge. And that says you cannot anticoagulate or you can anticoagulate. Kind of really up to you. The one exclusion, though, is that if you notice in the CHA2DS2-VASc score, 1 point can be obtained for gender. Female gender gets you 1 point. If your CHA2DS2-VASc score is 1 only because of female gender, you treat that as if it is a 0. Gender alone is not a high enough risk factor for a thromboembolic stroke that mandates anticoagulation. But if your CHA2DS2-VASc score is 1 for anything else besides gender, that's where the big hedge came in. Consider, don't have to. I can't really offer you guidance one way or the other. But what just came out is actually only e-published ahead of print right now. It's not even print yet, some cutting edge information for you, is the CHEST guidelines just came out that said if your CHA2DS2-VASc score is 1, go ahead and anticoagulate. They feel the risk outweighs the benefit of the risk of stroke outweighs the risk of anticoagulation, essentially. It's risk analysis. And go ahead and anticoagulate. So that makes things clearer. Do you choose to follow that? Well, that's sort of up to you. There's a brand new guideline. It's from one organization. There are other guidelines that say not quite sure. Personally, unless I feel the patient is particularly high risk for bleeding, you can use that has bled risk score, I go ahead and anticoagulate. And do I anticoagulate from the emergency department? Absolutely. I started in the emergency department. Yes, sir? The question is about aspirin and AFib, and there has been a lot of controversy about it. Aspirin is completely taken out of guidelines at this point. Aspirin does not appear to give any reduction in the risk of CVAs related to atrial fibrillation. So you can't hedge. Say, well, you're a 1, I'm only going to sort of maybe give you some medicine. I'm not actually going to anticoagulate you, I'll just give you this antithrombotic agent. The evidence is there that it actually doesn't work, and there is some evidence that says maybe being on aspirin as sole treatment for your AFib actually increases your risk of a thromboembolic event. So it's not only no benefit, there's some evidence here that says it may actually be harmful. An excellent question, thank you very much. All right, okay. So, anticoagulation risk. Why do I start this from the emergency department? Because most AFib-related strokes happen within the first 10 days after your onset of your symptom of atrial fibrillation. So if you convert or don't convert, if you're rate controlled or if you're rhythm controlled, most CVAs are going to happen within 10 days. So I don't want to leave you uncovered for any of that period of time. So say you have a follow-up with your primary care doctor in 4 days. Well, that's 40% of your major risk window right there. If I can start your anticoagulation right from the emergency department, I feel that I'm definitely giving benefit. I do not defer on that. I actually feel really strongly that this is something that has to be handled by the frontline provider, which is us, everyone in this room. Do people generally start anticoagulation from the emergency department for your new AFib patients? Yes, I see a lot of hands and a lot of nods. So good for you. That is excellent. I'm happy about that. Next question is, who sends their AFib patients home? You've rate controlled them, or you've rhythm controlled them. You calculate their anticoagulation risk. A few people. I love it. My hand's definitely up for that one. Right? Very little benefit to bringing the patient in if they are adequately rate controlled, or you have adequately rhythm controlled them, and you have managed their thromboembolic risk, right? You've checked all those boxes. Yes. Will they need an echo? Sure. Can they be done as an outpatient? Yes. Do they need serial troponins? No. They don't need serial troponins unless they had symptoms suggestive of cardiac ischemia. Like every other patient, the fast heart rate does not mean that they're having a heart attack. If they're having chest pain or they're sweaty or anything like that, treat them as if you would treat any other patient that came in with those symptoms. But AFib alone does not put you at higher risk for coronary artery disease. So great, I love it. So far we've talked about determining if your patient is stable and acting on that, if you're going to go with rate control or rhythm control, and the evidence behind your decision there, and the risk for anticoagulation. The last thing is, why did it all happen? Why did this happen in the first place, right? Again, as I said, the incidence of AFib goes up as you get older. So by the time you're 80, if you have AFib or new onset AFib, that's probably pretty reasonably related to age, but you have to investigate other causes. Younger patients, you absolutely have to investigate other causes. And there really are the big, bad, dangerous causes of atrial fibrillation. So we kind of get all excited about managing it, and I love it, and I love the evidence behind it and managing AFib, but you can't forget about thinking about what started this in the first place. Why is this patient actually here with this rhythm? And ruling these out is pretty straightforward. They are big things. They are myocardial infarction. Is your patient having symptoms of having a heart attack? Do they have symptoms of having a pulmonary embolism? Are they hyperthyroid? Pretty simple. Did they overdose on cocaine, as we heard earlier? Did they overdose on Sudafed? I've certainly taken care of a young mother, actually, who was a working mom, taking care of her kids, and had a cold and just kept popping that Sudafed to get herself energy and to decongest, and came in with AFib with rapid ventricular response. And then, of course, the extreme electrolyte derangements. Pretty straightforward stuff to figure out in the emergency department. This is important. There was a very unfortunate case recently where a nurse who worked at, as a story that was told to me, not at my hospital, presented with AFib, new onset AFib. She was, I think, 58 or 60, somewhere in that range, like young for AFib onset. She had acute onset of symptoms. She was perfect for cardioversion. She wasn't unstable. They sedated. They cardioverted her. She went into sinus rhythm with one shock. Everyone was very, very happy. They assessed her thromboembolic risk. She was a CHADS 2 VASC 1, but only for gender, so she defaulted to 0, went home, and then didn't show up to work the next day, because they they missed the pulmonary embolism that precipitated this in the first place. Everyone got very excited about managing the AFib and didn't think about why did this relatively young person go into atrial fibrillation in the first place. So it's great to make the patient feel better. It's great to get them out of atrial fibrillation, but don't forget about thinking about the reasons why they went into atrial fibrillation in the first place. All right. Any questions so far? Everything that we've talked about? Yes? Oh. CHADS 2 VASC score cannot be 0 if you're hypertensive. CHADS 2 VASC score of 1. Yes. I would anticoagulate that patient. Send them home on anticoagulant, yes. Mm-hmm. There another question over here? So, that's an excellent question. And the question is about when can you mix your calcium channel blocker IV and your beta blocker IV, right? Everyone asks this question. It's an excellent question. And I actually, because I get asked this question so much when talking about AFib, I did a literature search. I have looked and looked and looked, and there's nothing. There's nothing of any good quality that tells you when you can mix these two. So I went and did a retrospective look with a couple of my colleagues to see, kind of looking at patients that did have both these things happen. We just kind of looked at the hospital records, AFib, they got one, they got the other. And what I have found, it is not published yet, so I'm just telling you what I have from my experience right now, is that those two medications given within, we looked up to 12 hours, and within 12 hours of each other, there was no adverse cardiac events, so hypotension, AV block, any of that. So do I do it? Yes. I do. If the one doesn't work and I feel like I need to go on to the next agent, I do. Can I tell you that there's evidence behind the safety of doing it? I cannot. But my personal practice is that I do. I know you guys have a break, so I'm going to hang around for any other questions, but I love the questions that you're asking. So pretty much we talked about all these things. Think about duration, think about thromboembolic risk, and enjoy your break. Thank you.